Welcome to Africa Speaks of today. My name is Stephen Mulindwa, and I do hope that you always have a wonderful time in whatever you're doing. I want to emphasize that because the man upstairs never gives us the time, never gives us when he will take us or whenever any one of us will go. Some of you have chances to get to know when, but most of us don't ever get to know. So take care of yourself, do whatever you're doing, and make sure that you leave a legacy behind. Now, what have I got in today's Africa Speaks? I've got a wonderful gentleman here. He's been here before, and he's one of the most well-informed people that I've ever met. Can Africa healthcare future survive without donations from the West? That's the question we're going to try and answer in today's program. Can Africans' healthcare future survive without donations from the West? Of course, you've seen the newspapers, seen radios and all that about as far as healthcare is concerned in Africa now. Now, after independence, so many African countries inherited healthcare systems that should have grown with the population of the continent, but they never did. Now, since the early 60s, when most African countries gained independence from the West, they have depended on Western donations for their operations. Mark that. Almost a year ago, the President of the United States, Donald Trump, cut USA aid to so many African countries, claiming it was being misused. That's the word he used. How can the continent break the chain of dependency syndrome that has existed over 70 years, not just on health, but on all the other things that we depend on? These and many other questions we'll try and answer in today's question. Africa Speaks here. With me in the studio is Mr. Marshal Core, a global health system leader with 25 years experience in Africa. I've known him obviously on the political ground as chairman of ZAPO PC here in UK. ZANU-PF here in UK. Yeah. Welcome to the program.
Thanks for having me, Steve.
Yeah. Now tell our viewers about yourself and foremost.
Well,
the global the experience with the healthcare, so that we get to know that before we go anywhere else.
Thank you, Steve, for the opportunity. I've been working in health for the past 25 years. Trained here in the UK,
okay.
And then worked a lot in the NHS and in the private sector. My last roles were in the NHS working for Clinical Commissioning Group as a consultant. And I've done a lot of consultancy work in the last 15 years for the NHS, working with different ICBs and also clinical commissioning groups, and working with the NHS board itself as well. And that work still continues under our company called Horizon Healthcare Solutions.
Okay.
On the Africa front, last year I was appointed on the board of Diaspora Meds, which is a health insurance company, which is actually
it's a South African-based company.
Yeah, it's South African-based, but it's African-based. It's got a footprint in South Africa, Zimbabwe, Eswatini, Swaziland. Now they've also gone into the Kenya market and the Ghanaian market now. It's a fast-growing health insurance company, focusing mainly on Africa and serving the Africa diaspora community.
Now, there's a very good quote that I got, I think from the African Union. Africa is at turning points where health inequality, declining donor funding, growing diaspora engagement are forcing the continent to rethink how healthcare systems are financed and governed. That was a quote from the African Union. That to all African, African countries, let's rethink of how we are financed, because vis-a-vis the Donald Trump, when he, of course, cut most of the aid, and all the other European countries now are looking at balancing that. Now, in view of that, declined funding, declined donor, growing diaspora engagement, there is engagement from the diaspora, but still, the battle is there. What is there? What can be done to improve the healthcare services in Africa?
Yes, Steve, that's a very important question and critical question for the current position that we are in, speaking on Africa as a continent.
Yeah.
We're an emerging continent with a lot of youthful population.
Yeah.
And it's important that we find sustainable solutions to strengthen our healthcare services.
Yeah.
And it is important that we should never be dependent on donor funded.
Of course.
Because donor funded do not actually allow for us to develop long-term plans in terms of how we can finance our health. So it is critically important that the African Union takes a position which it has taken under the Agenda 2063 in terms of supporting many governments to attain sustainable health progress under what is called the universal health coverage, which who coined. So the most critical important aspects of this is that how are governments going to finance health? Well, if you recall, in 2001, there was the Abuja Declaration, which called for governments to dedicate 15% of their annual budgets on health spending. Unfortunately, not many governments have managed to live to those expectations. I think apart from only 2 countries, I think Rwanda and Cape Verde have been able to achieve that.
How about South Africa? I thought South Africa was
no, they have not achieved that. They have not achieved that. So what is critically important is to ensure that we come up with frameworks that can support our governments to build sustainable health infrastructure in terms of developing their workforce, making sure that critical services are available, especially at primary care service level, and also making sure that we embrace technology and innovation in ensuring that we can scale the accessibility of health across our growing urban areas and the rural areas as well.
Now, there are so many healthcare institutions in Africa. Each year, Uganda probably gets out something like 800 nurses. Kenya gets out maybe 900. Nigeria, Tanzania, all these institutions have got nurses and some doctors that are coming out. But still, the healthcare institutions, we're poorly funded by the government themselves. There are so many things in Africa. There's corruption, there's so on. But with all these numbers that are coming up, to the extent that Europe and even America and others are taking some of our human resources, people like you who are in the industry, how do you, I don't know, I'm trying to think, how can you help the institution, the African health institutions, in a way that, okay, let's put a stand on this, that if you're going to take our nurses, you're going to take our doctors, this is what is involved. Can that happen in an ideal world in Africa?
Well, it's possible to implement measures and policies that support that, Steve.
Yeah.
But I think before we even talk about the brain drain, I think we also have to we also have to look at that. Currently, we have a deficit of healthcare workers. I'll take, for example, Nigeria on itself. That currently Nigeria, a population of about 206 million, they are being served by roughly about between 76 to 80,000 doctors. If you compare with the UK, which has a lesser population, but currently with a balance of about 700,000 doctors to a population of about 60 million, you can actually see that we have a deficit of healthcare workers. I think...
Can we say that it's management, the management structures we have are not are the problem? That we don't really have governments that are looking at our interests.
No, not really.
Somebody could say that.
Not really. I think what we have not done well is to predict and plan ahead in terms of our growing population. Like as we know from a demography point of view, Africa is an emerging continent with a lot of population coming up in the next 50 years. So what we needed to do was to plan ahead and invest a lot of money in training healthcare workers, which currently governments are trying to catch up with now. So what we need is strategies that can enable us to churn on more nurses, more doctors, so that the average in terms of our population globally, we are lagging behind. I think we are 0.2 per 1,000 people in terms of attendance with a doctor, where the global ratio is 2 per 1,000 people. So we must work hard to ensure that we train more healthcare workers, we train more nurses, and train more doctors. You highlighted an important issue again of the brain drain. When we train these healthcare workers, we are losing them to Europe again. And this is an important aspect that we must look at the welfare of our nurses, the welfare of our doctors. But again, we can also look at policy measures that and negotiating in terms of bilateral agreements to enforce, to put pressure on the Europeans, for Britain, for example, to say, if you take X number of nurses, then you must invest back a certain amount of money as dividend to support ongoing training of healthcare workers. I think that would work well using the different multilateral and bilateral agreements that we have across negotiations with other different partners.
I want to look at the diaspora now. There are so many people. You've worked in of course, you work in the UK. You know, you've worked with the people in the diaspora who are also doing jobs in Africa. When you look at how Africa can be helped by the people in the diaspora, the doctors, the engineers, the lawyers, anybody who is trying to help healthcare in Africa, what are key moments, key things that they need to do? Because it's very difficult for one to get out of here and just go and trying to help back home. There are so many roadblocks that somebody's going to find. Because different countries have different methods and different means because of corruption, obviously. But when you're advising somebody who is in the diaspora and is trying to help the continent in terms of health, what are the key things that you've got to give him to do or her?
Well, I think, Steve, what we need to do is to encourage our government to utilize the diaspora as an essential tool to help in terms of developing our healthcare. Firstly, we have a lot of experts that are working in the healthcare industry in Europe and around the global world. Take for Zimbabwe, for example. Currently, we are sitting with about 15 chief executives working in different NHS trusts. In the commissioning landscape where I was working, we had more than close to almost 200 Zimbabweans managing healthcare budgets and working in the commissioning landscape in the UK. Those skills are important to harness them and bring them on the table to assist government in developing effective health policy that can bring in the good financial acumen of how do you develop health services. For example, if you've seen, the emphasis here in the UK is on making sure that the bedrock of healthcare is the primary healthcare services. In Africa, we are wholly dependent on wanting to have a lot of big hospitals, thinking that the best way of addressing our health concerns is to build healthcare, these massive hospital infrastructures. But actually, statistics can tell you that the best way to have a good healthcare system is to invest in health promotion, prevention of diseases in primary healthcare services, have access to GP services at all community levels and in the rural areas. So we need to harness our skills so that they can come in boardrooms with government and help to impact knowledge in our government departments, even if it's a matter of asking the diaspora to actually sit on health boards back home and advise in terms of government policy. We have the issue of regulation, which I think, again, is at a major setback in Africa. How do you regulate health? Health is a public good. How do you regulate abuse from counterfeit drugs and all these things coming into the country? I think the diaspora are positioned well to work with local partners at home. I'm not saying we don't have good healthcare practitioners at home. We have them, but we must also augment the advantage that we have, that now we have a very highly trained workforce abroad that we can tap into their knowledge. Not only can we tap into knowledge and ideas, we can also tap into investment capital. For example, right now, the remittance for Africa at a continental level, the diaspora remittance is currently standing at 50 billion, which is more than FD finance. Yeah. So we must sit strategically and see how can we convert part of that 50 billion, not into domestic use again, into investment platforms through bonds, partnerships with government that can yield better disposition of that investment capital.
The biggest problem, if I may interrupt,
Go ahead.
is I've been reading about this. The African Union says the continent needs to achieve its objectives of health sustainable goals by 2030. Now, they say that, but the problem is nobody's there to see or to give us, because even usually the information we get from the World Organization, the information about diseases in Africa and so on, when somebody's, what do you call this? When you're putting percentages on, say, for example, how many kids are dying of malaria, how many people are dying of HIV, how many, all these are put there in terms of, we don't have the actual figures. Now, when it comes to health as well, nobody's there not to supervise, but to foresee that, like you now, if you go to Zimbabwe, or I go to Uganda, for example, and I say, okay, we need to find out. You go to the health officials to give you the results. And sometimes most of this information is not there within the government sector. There need to be something like, okay, can we put somebody at the head of the African Union to supervise, to make sure that, you know, the global health, the Africa global health that we're trying to achieve is possible within this period, as they say. Somebody to be there. Like now, how do we prove what in Swati, how do you prove that that really something is happening and it's really going according to plan?
Yeah, it's an important point that you've raised, Steve. I think the most important thing is that we are living in the fourth industrial revolution, where data drives a lot of policy formulations and critical decision making. And in health, if you are going to make a lot of drastic steps in rectifying or improving health service delivery, you need technology that captures data.
Of course,
And what you are asking for is that we need to harness technology in terms of having access to information quickly, which can tell us in terms of the statistics, in terms of the risk presented by non-communicable or communicable diseases, so that at any given point in a district, we are able to identify the malaria cases by looking at the data. At any given time in a province, we are able to analyze the HIV infections using data-driven mechanism, which can now help to prescribe resources.
Do we need a body, a big body, forming another body? For example, there's the World Health Organization, there's the UN. But we need an African body, because if we have one major body that takes control, that has offices in Uganda, in Kenya, Tanzania, everywhere, so that we have one health body. You know, I can see Africa saying this, the African Union, for example. But it's more of an alliance than anything. It's not really a body. If we create a body, one particular health body that goes to foresee that these goals are being achieved, and if money is needed, it can be fundraised and raised. Don't you think that might be what?
I don't think we need a body. I think we've had so many conferences and seminars to discuss these things. I think what we need is more regional cooperation and sharing of information and technology. This is what is fundamental. There are companies already existing in Africa that can provide those services. Recently, I was working in South Africa on a project with a company called Digicore. They are an artificial intelligence-based company that have created a very unique app that you can actually use by putting your face on a phone. It can actually take your blood pressure. It can actually diagnose your temperature and do all these things. So what we need is greater cooperation within the continents itself. I think we have the graduates. We have technology experts abroad and at home. But what we need now is to come up with strategic measures of ensuring that within our government policies, in information and technology. Like, I was quite impressed actually with Zimbabwe quite recently. They launched an artificial intelligence strategy, and within that policy strategy, it's also addressing how artificial intelligence is going to be used as a tool to address healthcare challenges within the country itself. So in the diaspora, I come back again to the diaspora. Yeah. And the diaspora plays a critical role in ensuring that the expertise we have with people, for example, that are working in big global tech companies. Yeah. We should harness our intelligence and expertise that are working for companies like Google to come back at home, and we tap into their knowledge in ensuring that we develop data-driven structures in terms of diagnosis and in terms of also managing and tracking our health challenges.
Partnership. This is another area that has not been done properly. Partnership with the Western companies. You are here now. If there's a partnership that can be created between, for example, a company in Zimbabwe and a company here in terms of helping with the global health or something like that, so that there is when money is raised, it can be easily shared in terms of, okay, you're selling medicine to Africa, how much? Reduce the pay, reduce this, reduce that. A kind of partnership that can easily be formed between companies, healthcare companies. Can that exist and be of help to Africa as well?
Absolutely,
yeah.
And that's an important point you brought, Steve.
Yeah.
Global health partnerships are critically important for strengthening.
But they're not happening.
I think
they're not happening. This is where the problem is.
I think they
because,
are.
The reason why, sorry for interrupting,
yes,
is that governments are getting involved. Because I was an Indian, I met an Indian guy here who is a pharmacist, and I think they were trying to do something in Mozambique, and I think in Zimbabwe as well. And I don't know whether they tried Uganda or Kenya. One of the they went in there and they tried. They said, "Look, we could actually do this. We could actually, pharmacists bring these drugs in a raw form and then redo it, the malaria queen and all this, But the kind of partnership they wanted, but they were being sort of put down with the corruption, and so that if you don't give us this, in Zimbabwe, for example, the man said, look, the man told us point blank, if there isn't this amount of money at the table, I'm sorry, we are not going to take this. Well, so what I'm trying to say is that, are we the ones in the diaspora, people like you now within the industry, to foresee, to tell the governments that these partnerships are worth $1 billion a year, not just helping Africa, but also helping this way in terms of employment?
Well, I think we need to break down things so that we don't mix everything the discussions.
Yeah, I am mixing everything up.
Firstly, I think let's look at partnership.
Yeah.
Like here in the UK, for example, there's the Global Health Partnership, which has been working very well in Uganda and in Zimbabwe. I'll give Zimbabwe, for example, which I'm quite aware of, and I've attended some of their workshops. The Global Health Partnership in Zimbabwe has helped to train more than 3,000 healthcare workers in the last 2 years.
In Zimbabwe, yeah.
Yeah, in Zimbabwe. And one of the most important things about the success of this partnership is that they've been working with the Zimbabwe diaspora to actually go and do the training of those healthcare workers, which brings cultural alignment, understanding of the environment and of the terrain, which is actually very good. So I'm saying partnerships do work, but they do work if they are also locally led, either locally led by people on the ground who actually know where the challenges are, or they are locally led by the diaspora that we have. Okay. So we come back again to the diaspora aspect, that partnerships are more successful if they're actually led by the diaspora from Kenya, going back to Kenya to work with their government and assessing the importance of this. So my message to global health funding is please engage the diaspora of the respective countries and work with them. The UK global health funding has had a lot of successful inroads, especially in Zimbabwe, by engaging the Zimbabwe Life Project and by also engaging ZIMNA, which are local diaspora associations of healthcare that have fronted this. But again, let me go to the other important issue. the partnerships. Partnerships between governments. We recently saw, I think, the USAID announcing that they're pulling some of their investment in health funding in Africa, and they've come back with revised policy implementation, which again in other countries, I think 16 African countries have signed to that, but other countries like Zimbabwe and Zambia, they've refused. They've refused.
I wanted to know something about that, because when it came out, it's something which somebody was trying to explain to me and said, look, Donald Trump is a businessman, and because he's a businessman, he takes things on a business level rather than on any other levels. Now, countries that have accepted to sign, I think there are so many of them. I got the list here. I couldn't believe it. Botswana, Liberia, Burkina Faso, Madagascar, Burundi, Malawi. Apparently, Ghana is not there, but there's a lot. There's a lot. Nigeria, Swati, Rwanda. There is that element of the fact that, okay, this is how the partnership, this is how it's going to work. We're going to sell you ABCD. Okay, I want to find out, why did Zimbabwe and Zambia refuse?
Well, development cannot be prescribed. I don't think so. Bilateral agreements takes two to tango. I think Zimbabwe were not happy because of the conditions that were imposed in the agreement.
Okay.
There were certain conditionalities where data needed to be extracted, and when Zimbabwe asked that
where is this data going?
Where is this data going? For how is it going to benefit us? The explanations were not very clear, and I do support our government's position in that if help has to come, it must come on equal terms, where we can also protect the interests of our own people. You cannot just export critical data and demographical data about your people outside the country,
but with
clear understanding on how that data is going to be used.
They were insisting that the data was actually not leaving the country. It's just a question of it's going to stick in the country, but the whole idea is they collect it for research purposes and for learning purposes.
Yeah, but the research purposes has to be collaborative. The research purposes have to include our Zimbabweans again to be involved. It has to be a joint program of approach. We have to know that if you're taking data to go and use it for research purposes, let's have joint collaboration on it. You can't just take it and go and work with it without coming back on the table to explain what that data is. And I thought our government's position was very robust on that. I think help must not infringe sovereignty. Help is accepted, but it must be on equal terms. And I think Zambia's situation as well, I fully understand them as well. I think Zambia were even in a worse situation where their support and assistance was actually backed down by a condition that they will also export a certain amount of copper to the UK, and I thought that was very colonial in the architecture it was given. And I think we're living in a modern day world where collaboration and bilateral agreements must be on equal terms.
It's interesting why these two countries refused. Anyway, to leave that aside, the issue of working in partnership, and I've seen, I mean, the countries that the boards that you're on, the MEDS, Horizontal Care Solutions, the Africa Heading Foundation, Taurine Health Trust, and so on. You are in such a position where you can actually have a bigger voice in Africa, and you can actually talk to those people with the voices who can go to Africa. I don't know, when you're on board here, you look out for people within not just the health service, but with other areas, the actors, the musicians, the politicians, those who are none but Africans who have made it, the footballers, for example. It took Kanu a heart operation for him to realize the healthcare in Nigeria to go in and help. So is there a way in which you can influence African famous people to be part of the healthcare system, you know, so that they help not just in education, but in ensuring that we raise the funds that will help the continent in the various countries? Is there a way in that you can use that influence?
Yeah, certainly. I think there's relevance of influence in using our celebrities in supporting health promotion initiatives. I think we saw it in the late 80s and early 90s when HIV was at its peak, that there were a lot of health promotion activities taking place where commercials were embracing using our musicians and our footballers. But I think what is more important is to ensure that we work with our government and build systems that support sustainable funding. I think we need public and private partnerships in terms of building sustainable health funding, which covers areas that you have talked about creating the right awareness in terms of tackling our future problems. And I think the best way of doing this is for governments to embrace the diaspora and also to embrace private capital when it comes in. So I think for me the best solution is we must have systems where the government should lead, but then use the diaspora as a conduit or tool to bring expertise and the finance also, and then bring the private sector to also drive growth through banks and roping in the likes of the African Development Bank, the Afro-Exim Bank, to come in and dedicate a lot of funding in funding healthcare services. That is what is missing at this moment in time.
The problem, Mr. Core, is that Africa doesn't move in a straight line. The policies that you are saying are good on paper. They are very, very good. And okay, African governments can do this, African governments can do this. They will also do that, and mostly the politicians have very good language when they talk. So I'm going to build roads, I'm going to build schools, I'm going to... It becomes more like... I mean, it's good to talk about them, and this is what people want to hear. But when it comes to the reality itself, it becomes very different. And that is why I always look out for options. If there is any other options which goes beyond, especially in the private sector, where the government should be involved at the top level to allow something to happen. Because I was speaking to a Congolese lady who was telling me that if you're going to go to the government of Congo for something, trust me, it won't happen. You'll have to... And I said, why? I said, no, it's not going to happen in Congo. And I was trying to challenge her, and she said, look, I live in Congo. I've seen what's going on. So they have to... Congolese who are helping the structures in health and in construction in other areas are no longer using the structures of the government. They can only use the government to get licenses and so on. Now, I have that feeling that you, in your position at the moment, there could be another way in which you said, okay, we are going to work with the government, but we have a much bigger initiative as far as that is concerned. Because even in China now, the government foresees certain things and it lets them go as if they're in a private sector. It said, okay, if you brought up something and it's really working and people would support it, then the government suddenly comes to support it. Yeah. And that's why I'm saying that if you're looking at things that are happening in Zimbabwe or in Uganda or in any other African countries, which can easily be supporting the health sector, involve the government, but sometimes involve the government at a critical stage when there are certain things that are needed. But privately, you can try and push it before, and then the government sometimes will accept that. I don't know whether you have, you know what I mean. So there are certain things which you can easily move, because right now, I can see you being in a straight line. This is a cup of tea. It is, and it's a cup of tea. But when it comes to somebody in government, he's not seeing a cup. He's seeing money. He's seeing something else.
Yeah,
is there a way of overpassing that?
I think you're bringing the issue of corruption. That yes, it's a common factor that at times corruption stands in the way of development capacities within an African landscape. But think, Steve, what we must also be aware of is that there are a lot of critical ethical issues surrounding the provision of healthcare. For example, I'm working on a project to develop a healthcare center in Zimbabwe, privately. We've managed to acquire the land, so we are looking for the finance to build, and that finance we are going to local banks or investment partners abroad. But in terms of regulation and the business license locally, we need to work with the local authority, and we need to also work with government from a regulatory point of view.
Of course.
So this is why I was emphasizing that collaboration takes two to tango.
I know.
We need government from a policy position and from a regulatory point of view to protect people.
Okay.
We need the private capital from banks, investors abroad, and we need us, the local people who know the current problems that we have, the areas where we have the problems, to also have the courage to go in and say, we are going to invest now. So the biggest challenge we have in Africa is that we have failed over the years to also dedicate important resources from a private sector point of view to invest in critical aspects. Everyone is talking about wanting to invest in mining. Everyone is talking about wanting to invest manufacturing industry and tourism. But to be honest, if the health of the nation is the bedrock to all these things,
of course,
without health, there is no life.
I know,
so health is a priority, it's a public good, and even from a political point of view, I want to make it very clear here that even with my understanding of politics, one of the biggest assets for governments to aim election support is to deliver on healthcare and education.
Of course.
Those are the two critical fundamentals. So I'm encouraging also government ministers that are watching this program that it is important to ensure that we adhere to the Abuja Declaration of ensuring that 15% of national budget is adhered to health. Adhered to health. So these are critical, important things. Unfortunately, health is different from any other things that you can allow private investment to come, because regulation is also critical. If you're looking at the pharmaceutical industry, the import of drugs, there's a lot of regulation to also protect people. So government has the mandate also to ensure that whilst we are calling for more investment to come in, but in terms of policy and procedures, government has to also lead and ensure that they protect people when investment is coming.
How about education? Education is one of those areas which, I mean, Robert Mugabe did quite a lot. He invested quite a lot in education, so from what I read, unless I was mistaken. But at the same time, he invested in it that people were educated. But then the local level, from the local level, because if something is going to happen on the local level, people will fight for it. If you build a hospital, like we were trying to build a dispensary in my village, and licensed people and the politicians were coming in left and right, and the people stood up and said, no, we're not going to walk 20 miles away to the next hospital when we have somebody, one of our sons is putting something here. Oh, he needs this. I said, no. In fact, they even participated in building it, in my village. They did participate, make sure that, but all that happened because of education. We said, look, your daughters are giving birth here. Your mothers are giving birth here. You have to take a taxi to go to the next clinic somewhere. So why don't we have one of our own? And they supported it. They helped in building it. So others gave their work for free, for many hours. So what I'm saying is that we managed to do that because of education. So I'm trying to think, in terms of before we go anywhere with most of this, let's critically begin by educating the local masses, the importance of what they have, so that if they get to understand it, even through their own languages, they say, hang on a minute, my son will go there for treatment. So we need to make sure that this thing survives. They will even put money into it. I don't know whether you guys are trying to do that, so that from the local level now that you're building one, that can be a starting point.
Absolutely, and I think that is important. I think if we look from a national point of view, any social economic development cannot happen if the people are not at the heart or at the center of it. So for example, our Zimri healthcare project, the first thing we did was to do a feasibility study with the locals to actually find, where are people getting their healthcare from? So we did a survey, we engaged the community, we went into schools, we went into industries, and talked with the people that live in the area. So that is fundamentally important. And I'm glad you've brought this point. That essential and important investment or development into healthcare must be people-centered. It must be people-centered. You cannot address people's needs without consulting the people.
Of course.
So the heart of care should be people-centered. So yes, very much important that we need to engage the communities in the rural areas. What exactly are they looking for?
Yeah.
What exactly are the challenges they have locally? And you've mentioned the issue of health accessibility as well, that it's no point build one massive district hospital and people have to travel 40 kilometers to access it. So this is why we say that whilst it's important to have hospitals, but we must also focus on development of primary healthcare facilities like local clinics and GP practices where people can access a doctor within 24 hours or within a few hours of health challenges presenting. So you are critically correct there that the consultation with local people and engaging local people is essential if we are going to develop sustainable health services.
But the thing is, like I said about education and approaches that you have, because the key point in Horizon Care Solutions and all these other organizations that you're heading, one of the things that I'm looking at, if I may ask, where does the funding comes from? Because it's extremely difficult to get funding for anything nowadays. Do you have easy access to the funds with these organizations?
Well, funding is an issue, and the hospital project that we are working, like I said, we invested in the land ourselves.
Okay.
You know, we invested about 250,000 in securing the land. So we know that with that investment and title deeds on the land, we are now talking to banks, and we are also talking to partners abroad that are willing to come and work with us in making sure this.
You're not looking at donations.
No. This is a private project.
Okay.
But although once it has been set up, we'll be inviting some partners that want to come and pay for block packages for the elderly to be treated at no cost. That we can work on that. But for now, we need to make it sustainable by making money so that we can invest more in maybe reducing fees for the elderly and for the disabled.
Fundraising events like having football matches or something like that. That's where we did it back in my village. Fundraising events. We have a football match between one club and another, and the money raised goes there. You know, this is some of the things that we haven't really addressed so much in Africa, where you have you call those who can afford to come in and you auction several things. You put some things there for auctioning and some people buy them. You know, there has to be ways in which funds can easily be raised. You know, I don't know. I'm just putting the idea in your head now.
Yeah. I think we have to capitalize things. You know, it's easy to do fundraising for equipment for a local clinic. Like for example, in my rural area where I come from in Goromonzi, annually we do fundraising events to raise equipment for the clinic, blood pressure machines and everything. So it's actually a good method of sustaining rather than waiting for huge amounts of money to come. You can also educate communities to be self-resilient and sufficient in initiating local methods of raising money. So it's an important contribution that you have made.
Is it you said you are already doing it. How do you then because one of the things that we've always faced in Africa is that sometimes we don't export what we do. If we have done it in our village, we need to export it to another village. We need to export it to another, so that this thing is not remaining only in us. We've tried to do that in terms of educating and also doing films to show that actually this thing can easily be done. And another village could also do something similar. The lady I brought from Congo was telling me something similar. They're trying to do that, even showing videos and stuff like that, so that they say, hey, hang on a minute. A school, each parent could actually pay a certain amount of money, because this child will come to that school and the school has no nurse. Each child will pay maybe an extra in terms of school fees that could take care of somebody's a nurse's interest or a doctor's interest or something like that. I don't know. These are small ways in which
but I think
being a person who's going so much on the ground.
But also those measures are very important, Steve. But if we're going to leapfrog and get our health where we are, where we want it to be, you know, Agenda 2030 or Agenda 2063. I think what we need to do in terms of health financing is to introduce what is called health taxes,
Okay.
and mostly these health taxes are introduced on things like fizzy drinks.
Yeah.
They're introduced on like alcohol. So many governments put these health taxes. I think Ghana is a very good example that has worked very good models of health taxes, which we can use then to raise money for financing health from a government perspective. That has been very effective in Zimbabwe during the 90s and 80s. I think we introduced what was called the AIDS levy.
Okay.
That means everyone was taxed an additional 3% to put money into the pot. But again, the issue is to do with governance. When that money has been set aside for health, does it actually go to health, or is then misused into going into other things?
It's something else.
Yeah. So what I want to say is, I'm very confident that when I was looking at the reports of different countries in sub-Sahara Africa, I think we have now moved of edge as a continent in adopting some of these nuanced approaches in terms of health financing, and it's going very well. So you mentioned South Africa as well. They're also quite robust when it comes into health taxes, and in many other countries, for example, when you actually buy luxury goods, they actually put an additional fee that goes towards health financing, especially if commodities have a risk of causing non-communicable diseases like I've spoken, alcohol. So it's another measure which you increase tax on goods and luxuries that are also detrimental to health. Okay. So that's one of the best measures of supporting health financing from a policy level, at government level.
Now, with these organizations, the role of women, I always bring the women's role into this, because I've seen Malaysia in education. Malaysia did quite a lot. It educated so many women because they're the mothers of tomorrow. So many young girls were educated in Malaysia, and even now, I think Thailand and all the other tiger economies are trying to do something similar. When women have the education, how to take care of kids and so on, Africa hasn't gone so much in details in terms of education, and this is where you people come in. When these roles are coming in, if girls haven't been educated on, what is malaria, for example, it kills a lot of babies in Africa. What is clean water? What is all this part of education? I don't know whether that can be used as some kind of a packaging. As I said, when we go to an area, let's begin with the women. Let's begin with the girls, and then we can slowly move forward. I don't know whether you have that in Zima, MEDS, or Horizon Care, actually, these organizations which you are on.
Actually, that point is very important, because when you analyze in detail the universal health coverage, which promotes equitable distribution of health within communities across Africa, research has shown that the best and most effective development dividend in healthcare
is women.
Women are at the center and the heart of informal healthcare services. They're the best carers you can get in communities. So actually, the most important methods that governments can use is to train a lot of volunteers, especially in the rural areas. Where you can, when you find when you cannot have a lot of resources. So the mitigation contingency plan might be to invest in training a lot of female healthcare workers in villages. Actually, studies show that the best way of using finance when you don't have a lot of money is to roll out a training program of female healthcare workers in communities, and that has been most successful. And if you look actually at the SDG 3, you actually see that Africa has come to an understanding that all governments have come together with an agenda of mobilizing resources to train 6 million healthcare workers across the continent, and the majority of them are going to be women, which are the heart of care from a continental perspective and from a cultural perspective. So it's actually an important position. Women play a critical and vital role in terms of driving health education and in terms of providing what we call informal care roles within the community itself.
What is the biggest barrier in terms of healthcare assistance in Africa. The biggest barrier, the biggest problem that exists in terms of, say, for example, you're trying to help Africa, but then there's a barrier somewhere. I know there are things like corruption, so on and so forth, but then there should be something even within the healthcare system itself that is a barrier.
The biggest barrier is shortage of healthcare workers.
Shortage of healthcare
Yeah, we have a deficit of doctors, especially in mental health. We have a deficit of doctors across the continent. I think in some sub-Saharan countries,
there are more than
in some sub-Saharan countries,
institutions. That
in some sub-Saharan countries, when we are talking of statistics, we have one psychiatric doctor per 30,000 per 30,000 people.
Wow.
Yeah. So then imagine how quick can someone who's got psychological or psychiatric issues be assessed by a doctor.
Yeah.
So one of the major setbacks is the absence of health workforce. We have a deficit of healthcare workers, we have a deficit of nurses, and we have a deficit of doctors. I'm not talking about strategists and other people. So we need to address that. We need more nursing schools in Africa. We need more doctors, incentives to recruit, to train more doctors in Africa. And again, we know that one of the major setbacks again is the brain drain. That
of course,
once we train
the brain drain.
they go to Europe and we lose our workforce. So that's actually a major issue that governments must look at finding ways to support.
Getting retired doctors. The Baganda, that's my tribe, by the way, are trying to get doctors formerly from Buganda, that's a kingdom in Uganda, to get retired doctors in America over here, who are still healthy enough, who can still work, but they're retired here, to go to Africa. They're even getting doctors who are, white doctors, English doctors, American doctors, who can still work, to travel to Uganda, using mobile hospitals. When I was reading about this, I said, wow, because I had a tribal league, the head of the Buganda kingdoms here in the UK, Kabaka's representative here in the UK, and he was telling me of what they are trying to do. They get mobile hospitals for clinics for the eyes, clinics for any other thing. But some of these doctors are retired. Here, they could, 60 or 70, you can retire, but you could still have your knowledge if you're still healthy. Why not? So they're taking them there to help. I don't know whether this can be another thing that might come in and help with other parts of Africa, so that it's not only centered in one area of Africa, because I think South Africa is trying to do something similar, but the Kingdom of Buganda is doing that.
I think that's actually an effective method. Some of the work that we do with the African Healing Foundation is we invite experts, doctors, who wants to come on holiday to Africa.
Working holidays.
Working holidays to actually come to Africa. That whilst they are holiday, they see in the country, they're also seeing patients. We've done that well, and it has worked very well. And there are other
in Zimbabwe,
in Zimbabwe and Kenya as well. But there are other initiatives around Africa where doctors go to Africa on vacation, and at the same time they are doing some work on hospitals. That has worked very well. There's a hospital in Zimbabwe called Karanda Hospital. Most of their doctors that come to do surgeries there are voluntary. They don't actually pay for them. They actually come on a work experience.
They're retired. They're voluntary. Okay.
Or they're voluntary. And utilizing retired workforce is also important. It's done here in the NHS. The voluntary sector here is huge. If you go into NHS hospitals, you've noticed that sometimes on your reception, you are received by retired people that are working voluntarily to support the healthcare system. So those are some of the methods which we hear from the diaspora that are exposed to that, we can take them back home. But certainly they do work. One of the other important facets which we can also work is for governments in Africa to also work for incentives for their professional health workers in the diaspora when they come home, even on holiday, and give them on attachment. Research we have conducted with the African Healing Foundation always say that a lot of our nurses and doctors, when they go home on vacation, they are also willing to do some charity work and support local institutions. But it needs to be coordinated. So it's quite important like when I emphasize that diaspora engagement is important, because it's important that you can actually use also those measures and as a way of optimizing support of local health institutions back at home. So it's critically important that government also looks at giving incentives for the diaspora when they're coming back home. For example, I'll give you an example. You can come up with measures like, if you're a nurse and you're coming back home, you get a duty rebate on whatever you are bringing in at customs if you are going to do X amount of hours serving into the communities. So those are local incentives that governments can adopt in incentivizing the diaspora returnees to be active healthcare workers back at home. So there's so many measures, and I think it does work as well. Looking at retired personnel and looking at working with the military sometimes can also be a major asset in supporting development in terms of health initiatives.
There is a big voice now in the diaspora, and here in the UK alone, there's a massive voice. But one of the problems that I've seen is that there is a disunity as well, in terms of, say, for example, we are all here in the diaspora, but then if you're trying to gather people from Zimbabwe who are in the diaspora, unless there's an initiative that will bring them together to talk about Zimbabwe, or even if you're getting Ugandans or you're getting Kenyans, or even getting Africans as a whole in the diaspora, and say any Africans in the diaspora, let's have a newspaper, or let's have something that will gather all of us, and then start look at the interests of Africa. There's a huge division, and that division, you probably get few Zimbabweans here, you won't get a huge amount supporting any of the things in the diaspora. Why is this so?
Well, I think those are common problems that you get when migration happened. Sometimes when people migrate, they also migrate with the ethnic or conflicts and ethnic differences as well. So the tribal issues sometimes resonate again, especially in countries that have got bigger tribal divides. But what I've seen in the last 15 years, having worked with a lot of diaspora organizations from Southern Africa, I've noticed that there's unity of common purpose in addressing issues back at home. There's been a lot of appetite in people wanting to come together. We have a doctors organization in Zimbabwe that has got close to almost 200 doctors in a network. And the majority of them went to even setting an online consultation services back home, which you can actually sign on and get a service from doctors that are over here, and they can provide the service. So I think the appetite is there for diaspora support and diaspora integration in terms of supporting back home. But I think what is the disconnect now is the appetite for government to embrace the diaspora. I've got so many models that I've seen in healthcare that have worked. I was recently quite in Ireland and working with a women's group that has been doing amazing in addressing HIV awareness back home. So there is appetite for cooperation, but what we need now is government policy to shift also and advance purposeful engagement with the diaspora.
That is something that is very difficult to control when it comes to governments. Listen, I've dealt with African governments, and I've talked to government leaders. The sound bites are almost similar. From Kenya, from South Africa to Uganda to the whole of Africa. The sound bites are the same. Blah, 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 blah. Then when it comes to the reality itself, say, look, can you prove in front of me that this thing is really real? And the person will tell you, no, I can't. So I like the methods, and I don't know whether you're still in politics or not, but you know what I mean anyway. You know what I mean. So, right, we're coming towards the end of the program, and there is something that could be of a much impact in terms of whatever you're bringing together. Because the biggest problem I've noticed is that it's easier to put these things down, but when it comes to implementation, that's where things become difficult, especially if it's only us as Africans who are involved. And one white friend of mine told me that, Steve, I think the best, he told me, he said, look, I don't want you to think that I'm a racist or not, but I want Africa to develop. But in order for Africa to develop, you've got to have a lot of white people involved in most of the plans that you have, because we have effective ways in which when we say we are going to do certain things, we tend to stick to what we are going to do. But sometimes you people don't stick to what you said you're going to do. You put them down, but then somewhere along the way, either you're diverted or something. But if you invite us and we are part of the teams, then we are going to be more practical, as we are practical here in our own countries. When you look at that, do you think that, was it right?
No, I think I want to be clear.
Because when you look at things which are managed by them, companies which are managed by them, you'll see a slight, you're always going to see an edge than the companies which are managed by us.
But I want to be clear, Steve. I think we as a people, Africans, we have come out of age, that we have the capability and the capacity to deal and address our own issues. We have the billionaires that can fund this, the Dangotes, the Strive Masiwa.
I agree.
With people that are owning banks now. I think we are now in control of our destiny. If you look at these major institutions in Europe, you know, that you may think of, at the heart of the intelligentsia of those institutions, you find that at the
Africans are there.
At the forefront, Africans are there. I think what we are actually suffering from is paralysis of analysis in terms of not using what we have. We actually have the...
What is that? Could you repeat that? Paralysis
of analysis. We overanalyze our problem and think that there's someone from the moon that is going to come and solve our problem. But we have we have the local intelligence now. If you go across Africa, so many vibrant young graduates coming out of university, you know, very thriving. I was working on a project mentoring some 2 young boys in Zimbabwe that are actually in university. They've set up an application. Their company is called Tariro Trust. They've set up an application to assist women in the rural areas via a mobile phone application to prepare for birth, to check for all the complications using an application. These are boys that have never been to Europe. They are educated in Africa. They are still at university. They've set up a company. It's registered. Yesterday, they got a license from Portras in Zimbabwe so that they can start collecting data and be used for national development. So that is an achievement. I think gone are the days that we should look to the West for ideas. We have the ideas, and to some extent also we have the finance. It's high time we trust our own initiatives, and I am here to critically state that development of healthcare in Africa should be locally led, and it should be locally implemented, and it needs obviously funding from external partners and local partners. But the solutions are with us,
No, I'm not saying. Don't get me wrong. I'm not saying that we shouldn't deal with things on a local level with ourselves. We should be We should own what we do. We should own our country. We should own everything. But what I'm saying, in order for us to bring in the standards, we need them to a certain extent. Because even a Chinese man told me this. He said, listen, if you bring the Chinese in, the Chinese are hardworking, blah, blah, blah. And he said your standards will come up. Because what he saw in Africa is that there is the lower base of way in which we take things for granted. And because we've got the sun, got everything, we don't really look so much at... you know?
No, without a doubt, yes, we can benchmark... we can benchmark quality with global standards. It's important, yes, we can do that. We can tap into the models that the Chinese are using, and we can tap into the system here in the UK, how the NHS is run. For example, here in the NHS, you have government at the center of health funding, but they've created an independent arm called CQC, care compliance, which then deals with the regulatory aspect of care. Yes, we can take those models, they work, but I think at the heart of growth and development, it should still be with the responsibility should be, we cannot outsource that. You know, yes, we can benchmark on terms of standards, ethics and procedures, go to India, take their models and see if they work. But when it comes to implementation and send the agenda, it must be the heart of us, the Africans.
Okay. Right, I just want to say thank you very much.
Thank you
very much for coming to the show.
For making this a very interesting discussion.
I know, I know. Thank you very much
for
coming on the show.
Thank you.
I just want to say thank you very much for viewing us, and I hope we'll be together again for another edition of Africa Speaks. Thank you, and may God bless you all. Once again, thank you.
Thank you.